Respected teachers, colleagues, and friends, a very good morning. Today, my presentation is on ultrasound biometry. Does it have a role in today's practice? So, today's cataract surgery has become a more of a refractive surgery. So, the refractive outcomes after the cataract surgery mainly depends on axial length, keratometry, anterior chamber depth, and the lens formulas, among which the key factor is the axial length. We all know even a small 1 millimeter difference in the axial length can give a 2.5 diopter difference in the postoperative refraction. So axial length can be mainly determined by ultrasound biometry or optical biometry. My talk is on ultrasound biometry, so I'll be talking only about ultrasound today. And there are two methods of measuring ultrasound biometry. It can be a contact method or an immersion method. So the basic principle behind the ultrasound biometry is it uses sound energy. The A-scan probe passes a thin sound wave, which penetrates the parts of the cornea, and the sound waves are reflected back. The reflected waves are observed in the probe, and they are projected as spikes. So based on the spikes, the readings are taken, the axial length is measured. The ultrasound probe uses a high frequency of 10 megahertz, and this high frequency allows better penetration of sound and also excellent resolution of the structures. So as the name indicates, this is a contact ultrasound biometry, wherein the ultrasound probe is directly placed on the anesthetized cornea when the patient is looking in a straight gaze. So this is a picture of that. The probe is placed on the anesthetized cornea, and the sound waves pass through the structures, and the sound waves are reflected back based on the similarity of the structure. So the first wave, what we get is the corneal spike here. Then we have the lens spike, anterior lens spike, the posterior lens spike, and the retinal spikes. So the spikes are of good amplitude if taken in a proper and correct manner. But in contact ultrasound microscopy, a lot of factor depends on the technician. The technician has to be really experienced to avoid compression of the cornea with the probe. In case of compression of the cornea, there can be erroneous wrong readings, which can give a false axial length and a false IOL power calculation. And the posture of the patient is also very important. The patient has to look straight at a target. As I already told, a 1 millimeter error can cause a 2.5 millimeter difference in the postoperative refraction. Because of all these side effects or disadvantages, then came the immersion ultrasound biometry, wherein there is a small scleral shell, as we see in this picture, the Prager shell. A coupling fluid, distilled water or saline, is injected into the scleral shell, and the probe is placed in the coupling fluid. So here we see a patient lying down, and the probe is placed in the coupling fluid. So this immersion technique minimizes the technician variables. The corneal compression is minimized, leading to more reproducible results. So this is an ideal A-scan which we get from an immersion technique. The probe is inserted into the coupling fluid. So the first spike which we get is the interface spike. Then we have the corneal spike, as we already saw, and we have the anterior posterior lens spike and the retinal spike. And then we have the orbital tissue spikes. And this ultrasound biometry, the machine also has, the latest machines also has incorporates all the formulas for us to give accurate IOL power calculation. And for an accurate A-scan, a proper calibration is mandatory. Accurate positioning of the patient is very important, and proper sterilization of the shell is important. So positioning, why is it important? This position is wrong. The patient has to lie supine without any tilt in the head. Why? Because when there is any tilt in the head, the sound beam which passes is oblique to visual axis, and part of the returning echoes is reflected away from the probe tip, and the spikes are compromised. So it might give a wrong axial length. However, when the patient looks straight, most of the echoes which are reflected from the structures are perceived by the probe, and they give good quality spikes, and we get a proper axial length. Sterilization of the shell is also very important. The shell and the probes can be soaked in alcohol or hydrogen peroxide for at least 5 minutes, and then they have to be allowed to dry completely and cleaned with BSS before using for a next patient. So this is the ideal A scan. As we saw, there are various spikes which are caused by the reflection of the sound waves from various structures, and these spikes should be of good amplitude. The height should be good. It should not be like blunt or variable among the structures. And we should also have good orbital spikes. So in this scan, we find there are multiple steps and ridges, and the spikes are not of good quality. So when we get such kind of spikes, we should ideally repeat the scan. And similarly, when we see here, there is a corneal spike, but however, the lens spikes are not very clear. There are multiple ridges, and here that we don't see any orbital fat spikes. So this particular scan is probably taken along the optic disc, and these scans should be repeated. So, and when we are dealing with a very dense cataract, the sound waves might have difficulty in penetration, and so we might not have good quality spikes. So in that situations, in an ultrasound, we have to increase the gain settings. And when you are dealing with a patient with silicone oil filled eye, the velocity, the mode has to be changed to silicone oil mode, because the velocity in which sound waves travel in silicone oil is relatively different. It is slow, so that can be pronounced sound attenuation, and that it can erroneously give a false axial, long axial length, which can affect our IOL power calculation. So what are the advantages of ultrasound biometry? Ultrasound biometry is very good in dense cataracts, in very dense posterior subcapsular cataract, high myopia, patients with no proper fixation. It is of all the parameters which I have told, the cost effectiveness is the biggest advantage of ultrasound biometry. Now let's see what literature says. This was one of the recent publications by Dr. Untitled Chapter et al. They had compared ultrasound biometry and optical biometry. So ultrasound biometry actually measures the axial length from the cornea to the internal limiting membrane. The machine arbitrarily adds 200 microns universally for all eyes to give the axial length. But in optical biometry, the measurement is taken from the cornea to the retinal pigment epithelium. So a true axial length is obtained. So the errors with optical biometry is less compared with ultrasound biometry. In ultrasound biometry, the modes have to be changed for aphakic eyes, silicone oil filled eyes, and pseudophakic eyes. However, there is no adjustment required in optical biometry. Ultrasound biometry, both the methods are contact methods. However, optical biometry is not a contact method. And there can be factors of corneal compression, particularly when we deal with contact method of ultrasound biometry in ultrasound biometry, but there is no issues of compression in optical biometry. So generally, the optical biometry is definitely superior. However, when it comes to cost effectiveness and efficiency, ultrasound biometry is definitely superior, and it is highly practicable in today's practice also. This is just a comparison of the ultrasound biometry with the optical biometers. The current generation and the latest IOL master, which is very efficient, is I think 10 times more costlier than the basic ultrasound biometry, which with which we can actually do all the IOL power calculations successfully and efficiently, except few case scenarios wherein we might definitely require the newer generation techniques. So I did a small survey among the Madras of city ophthalmologists to find out what type of biometers they have. And in the survey, I found that 60% actually had an optical biometer and 40% had an ultrasound biometer. But when I asked, do you use ultrasound biometry, 90% said that they still use ultrasound biometry. This itself proves that it's not obsolete. It can still be used in today's and future practice efficiently. So to conclude, ultrasound biometry can be considered for axial length and IOL power calculation when properly done. It is safe and very cost effective for IOL power calculation. Thank you. I would acknowledge Ramesh sir and Atik for helping me do the presentation. Thank you.